levels. I can see that Bernie, as our president of the Association of British Paediatric Nurses, is looking nice and cool there, Bernie, which is really, really fabulous. And we're delighted, Jean and I, to actually be having the conversation this afternoon around children's nursing, its importance as a profession, but also the future. And to have so many colleagues on the call is really, really fabulous. So importantly, I'm going to pause and say hello. My name is Kath, in memory of the fabulous Kate Granger and her amazing work, actually just reinforcing the importance of making introductions. As Gina's already asked us, we've been popping in the chat box our roles, our names, where we're from. It's always incredibly helpful in terms of ongoing networks and connections as well. So if you haven't been able to do that as yet, then please do pop your introductions in the chat box. Jean, I can see that you very kindly popped the record button on. That's incredibly important in terms of colleagues who might not be able to actually join us in terms of listening back, but also in terms of using the insights and the information during this discussion for our ongoing lobbying and policy work with regard to really making sure that we can advance the profession of children's nursing moving forward. Now, I've got the joy of being the deputy chair to Jean. Jean, shall I hand over to you to do your introduction?
Thank you very much indeed, Kath. Yes, I am privileged and pleased to be the chair of ABPN, and in conjunction with Kath, with President Bernie, with Fiona Smith, Mark as the trustee, Mark Whiting, and other colleagues on the call, we are striving to really bring the topics that are concerning us day to day to these webinars that we host for ABPN. And the other thing we always want to do is to celebrate what we do and to acknowledge the hard work that everyone does. Many of us do know each other. We are quite representative of the 4 countries, as Kath has said. And the other thing is that we represent children's nursing wherever children do need nursing care. So we thank you all, and we have hoped that today would bring out some of the things and concerns that people have raised with us at our World Cafe workshops, in personal emails, in the many contributions we've made to different meetings about the recognition of the unique value of children's nurses. So it's really a discussion today to stimulate a conversation that we may be able to take to people who can make a difference. Nursing and Midwifery Council is someone, a body that we actually do want us to, that we want them to listen to us. We have many years of experience now of saying what the risks are of not having designated children's qualified nurses with a unique registration. And we've also outlined the benefits. So Kath, may I come back to you to enhance what I've been talking about there, please?
Absolutely. And Jean, just before we launch into the discussion, what I do want to do is just flag an ongoing lobbying and advocacy opportunity that we've got, importantly thanks to the Association of British Paediatric Nurses. So I've just popped in the chat box. Sharice has done an amazing job recently of updating the web pages for the ABPN, and on those web pages there is information around our first ever National Children's Nurses Day, which is going to be on Tuesday, Tuesday the 30th of June. And I'm sure that everybody on the call is already very aware and is no doubt actually planning events and celebrations. I know that when I've been chatting to colleagues from across the country, they've talked about holding teddy bears picnics to get children involved. They've also talked about inviting executive teams to their children's areas to walk and talk so that they can make sure that they are influencing upwards as well. So there are lots of elements of celebration, but I'm hoping that some of the discussions that we'll have today will be really helpful as we actually move those celebrations forward very locally. I know that in London at Barts Health, we've got an afternoon tea planned where our frontline children's nurses who are delivering direct care can have an opportunity to actually meet with our chief nurses, our directors of children's nurses, in terms of explaining what they do, some of the challenges and the opportunities. And we've also invited our local universities to actually come along. So there's going to be lots happening, and there's already been quite a bit of press coverage with regard to that first ever National Children's Nursing celebration as well. So we're really, really excited about that. And if colleagues have got elements that they want to share about their plans during the conversation this afternoon, then we can absolutely pick up on that. But as Jean rightly said, what we wanted to do was have a conversation around children's nursing. What's our unique contribution? Have we got consensus on that? Are there opportunities where we could grow the evidence base around the unique difference that children's nurses actually bring to improving child health outcomes and children's lives across the UK and beyond? Are there blind spots? Are there things that we're not aware of that we should be thinking about as we move forward? And how do we absolutely strengthen the future of children's nursing as we continue on our journey? As Jean actually rightly highlighted, we do need to keep influencing the Nursing and Midwifery Council. How do we do that collectively? Where are opportunities? So I've got a couple of questions here that sort of, I've been thinking about in terms of what do babies, children, young people and their families need from the healthcare system? And what workforce provides that safest care for our babies, children and young people? So I just wonder as to whether I can open it up. What do our children need from us as children's nurses? Feel free to pop your hand up. We would love to actually have people engaging with us, or feel free to actually use the chat box as well. But seeing as Bernie is our president, Bernie, you've always got such wisdom. Can I pass over to you? What do you think? What do our babies, children and young people need from us as children's nurses?
This is a moment where I wish I wasn't the president and been introduced as being wise and all-knowing, because I'm not. I think they need our passion and they need our advocacy, and that is not just in our practice settings, but also in kind of everyday life. I think we need to talk about children's nursing. I think we need to, I know I'm one of, I don't do it all the time, but I will sometimes go and talk to our parliamentary representatives when they are sitting in the library at, in the town that I live in, and start to talk about the things that are important for children. Because if we don't talk about them outside of our own professional kind of network, nobody really understands children. They represent such an important part of our communities. So I think we need to advocate for them, not just, you know, within our work settings and with each other in networks as brilliant as this one is, and other ones like this, but actually in everyday life, talk about them to people when you get the chance. Be proud of being a children's nurse. This is my 50th year in children's nursing, and I'm still absolutely loving it, absolutely privileged and proud to be part of it. And I've been talking about children for a long time. So I think, and there's still many things that we need to do. So that would be me.
And Bernie, as ever, I can see that Mary's clapping there. That wisdom in terms of that consistent advocacy is really, really critical. The other thing that sort of, you know, strikes me there is that element of us being trusted adults to babies, children, young people and their families as well. We are in a very privileged position as healthcare professionals to be able to actually do that constant advocacy. I wonder as to whether anybody else has got any other reflections. Go on, Mark, go for it. I can see you've popped in the chat box. Share your thoughts with us. It'll be a first if Mark can't take himself off mute. Oh, Mark, I'm so sorry. It's not working there, is it?
Kate's popped something in the chat, so we could go to Kate whilst we're waiting for Mark to debug himself.
Perfect. Kate, over to you.
Yeah, well, I was just thinking about, obviously, as children, you know, if you compare kind of children's nurses to adult nurses, it's about recognizing those milestones and those kind of experiences at the different milestones, and being able to kind of put the two together in terms of the health and well-being, and ensuring kind of inclusion and access to those different childhood experiences alongside their peers, and it not being you know, trying to facilitate and overcome barriers to allowing that. And I guess I was just about to type something in as well in terms of you know, the different perspective in safeguarding. So I think someone had put around kind of the context of family experiences, and it's just it's different, isn't it, between adults and children in terms of kind of those safeguarding and those safety, you know, safe boundaries, you know, environment, parenting and things like it's different. You have to see it through a different lens, and you only get that from kind of those fundamental things that you're taught in terms of your children, you know, your children's nursing.
Absolutely, Kate, and I really like that important reflection there on that developmental perspective and those milestones that you were actually talking about, and that knowledge and insight on that alongside that safeguarding. So I wonder if we can pick up on that sort of developmental component as well. Fergal, let's come over to you.
I think
would you mind introducing yourselves just as we're heading round?
Yeah, my name is Fergal O'Malley. I'm a currently an advanced neonatal nurse practitioner. I was previously an advanced nurse practitioner in PICU. I've been nursing children's nurse, came to the UK in '95, I think, from Australia. I think for me, what are specifically in the newborn period, it's the understanding that it's more than just a patient, it's a family. And I think, I could be wrong, but I trained as an adult nurse in Australia, and so it was about disease process in a single patient. And I think more and more we're understanding the impact of a holistic approach to the infant and family. We have maternity neonatal voice partnerships to understand our service user perspective, and that's more and more very much embedded in what we deliver every single day. And I say to the team all the time that we create experiences for families. So once we understand the medicine and what to expect, we actually create an experience for that family or something they don't expect.
Mm.
And so that's a precious moment to support them to walk away from the situation feeling they were listening to communicate and they understand what's happened. So it's a very different perspective as opposed to a single patient, I think.
And reinforcing that is just so critical. And, you know, those precious moments that you were talking about there, Fergal, stay with those families forever, don't they? Really, really powerful. Thank you. Any other reflections? Jenny, would you mind introducing yourself and then over to you?
Yes, I'm Jenny King. You might not see a camera of me. Hang on a minute. I'm a nursing lecturer at Edinburgh Napier University in Scotland, and I've helped implement GIRFEC and other policies across Scotland in my career. If that helps you out, there was a massive national delivery plan for children and young people services in Scotland, and I was the project lead for it in 2009. I've also got 3 children that are 2 13-year-olds and a 14-year-old. And integral to supporting their education and GIRFEC across Scotland, there also needs to be an understanding of healthcare professionals who work in children and young people's healthcare that can support education for those children as they go through and stand up for their rights. And I do that as a parent because I'm a children's nurse, obviously, and I really push GIRFEC for supporting all my children. But I suppose for me, my concern would be is if we went for a general nurse training across the UK instead of paediatrics, it may not then align to being able to provide the best support for children and young people that aligns to all the other policies that are out there that actually have really put children and young people at the forefront in the last 20 years. I'm 30 years qualified and started nursing, so I am quite experienced as well. Okay, I hope that's helpful as sort of like a comment from myself.
Incredibly helpful, Jenny. You know, all of, you know, the voice, the participation, the advocacy work in terms of really bringing to life the rights of the child just really reinforce the importance of a workforce that is specifically trained and competent to actually meet children's needs.
Definitely, and Scotland has a 4-year wait for children and adolescent mental health services at the moment, if perhaps somebody's referred for autism or ADHD, unless you pay for it privately. I've got a particularly misbehaved 13-year-old boy who I know he's not got them, but I've had to really push forward in my own school to ask for counselling for him to help him out a little bit. And also, when they said they were going to pull away their counselling because he was misbehaving, I said, but then I've as a parent, I've advocated mental health support for my child. Are you pulling away mental health support for my child when he needs it to be able to get his education? So I think overall, and I only do that because I'm a children's nurse, so I know full on the rights of the child and the parent, but actually any children's nurse would be able to do that for anybody. And because schools are aligned to working with school nurses who have to have that sort of training, then actually, you know, there isn't, and for me, there's a real big progression to always push forward the importance of children's young people's nursing in Scotland. And I know Jean from a very long time ago. Jean knows I like to advocate for paediatrics. I worked with her when I worked with my other job. So yeah, but yeah.
And Jenny, I'm just reflecting on that advocacy element. In Newham, we have got one of our nurse specialists who works in our care leaver hubs, and our care leaver hubs actually bring together a multidisciplinary team. But it's a lovely kitchen area, television area. It's got computers. It's got social workers there. But she absolutely advocates for those young people with regard to their mental health, particularly providing them with sort of, you know, frontline support when they actually need it, support to access services, but then fast tracking them when they actually need that critical intervention as well. And again, that advocacy role is so important from a mental health perspective.
Yeah. And just finally, before I dip out, I will also say that there's not been so many government policies recently that really push forward children and young people. So I think as a field of nursing, we still need to ensure we are feeling we're there for them, if that makes sense. So, for example, in Scotland, the last sort of massive piece that looked at children and young people's services was the National Delivery Plan, which was 2009. And a lot of work went into implementing. There's been lots of other policies that do, but that one was really clearly for children and young people because there was obviously a requirement that that support was needed for everybody in the whole of like Scotland. So I think it's really important as a field of nursing, we still have our own sort of like championships to be paediatric nurses.
And Jenny, I just written down, and I am one for a bit of a strap line and a hashtag, we're there for you, in terms of actually being there for our babies, children, young people and families as we move this forward. Really helpful reflections. Thank you. Veronica, may we come over to you?
Thank you, Kath, and thank you, everybody. I'm Veronica. I'm a children's nurse and an adult nurse, and I've been around in the health service for like 50 years, so feel very ancient. But I've learned such a lot from some of the colleagues here on the team, Bernie, Kath, and Jean, over the years. I've learned such a lot, and I think the advocacy is the big thing, isn't it, that we do as children's nurses. But I think maybe it was Kath who mentioned, or maybe it was Jean, sorry, about the need for some evidence. Currently, I work in the university, working with children with long-term conditions and their families, and helping to develop and evaluate interventions to help them to learn to self-manage their condition so that they can become confident and look after their condition as they become adults. And so that's where my sort of activity is at the minute, but I will be retiring later on in this year. But I'd like to sort of pose a challenge to the people who are who are in children's nursing now, who've had the benefit of having an education through university from the start of their career, unlike me, who was trained differently. I'm very proud of the training I've had, but I will enter the world of education and then research mid-career. So I know that we've got the tools there and we've got the will, and I think, you know, what we're saying is we need to prove, really demonstrate, we need to demonstrate to the world what it is that's different about children and young people's nurses that helps children, young people and families, as opposed to if we were an adult trained nurse. And having been both, I feel I've got a reasonable idea of the differences. So just to say that I think there is benefit, there is potential there for developing, using the skills that we have in research, the NHS, to start taking forward grant applications and getting some evidence on what it is that makes children's nursing different to adult nursing, for instance. And the other thing that one of you mentioned was the NMC, and I was asked to be a member of, I'm just reading it now, the Code and Revalidation Review Breadth of Practice Advisory Group. It's ongoing at the minute. So I don't know if you're aware of that, and I do feel we could do with more children's nurses on that. I was asked because I've been quite heavily involved in developing family nursing as well, working with family nurses around in other countries as well as in the UK. But on that group, I always feel like the lone voice that's saying, but what about children and young people as well as adults who are members of families? So I think there are those things I'd happy to feed back on that and share that with you, Bernie, Jean, Kath, whoever, the NMC. But there is maybe a route in there to that program that's developing the code and revalidation reviews to fly the flag a bit more for children and young people who are beneficiaries of health service. So those are just a few pointers, really, just based on a long history, and it'd be lovely to see the continued growth of the evidence base behind children, young people and families nursing that would help to demonstrate to the world what it is that makes us different. Because I feel everywhere you go in the health service or the university world, you need to keep flying the flag for children and young people, because they're not there always to do it themselves. But when we talk to them in the research world, often they will say, oh, that nurse was really understood what we needed in my healthcare. She's a children's nurse. She understands how children and young people work. And also we have the skills to adapt according to the developmental stage of the child and young person, because unlike adult patients, our patients don't stay in the same developmental stage throughout the period of time that we know them. So those are just really a few thoughts to share, and hopefully to prompt a few ideas for the next generation of nurses coming along with their skills.
Veronica, can I just say I'm absolutely delighted that you're going to be at the table for the NMC code work and the revalidation. And I think sort of, that opportunity for us all to actually think about how do we get involved in actually influencing is really, really important in these discussions moving forward. I was just doing a piece of work actually at Barts only this week, thinking about our children's nursing deck and the content within that. And it's a bit of a pocket guide that all of our children's nurses actually have across the organisation. And there are some really clear principles in the General Medical Council relating to children, but actually we haven't got those in the same way from an NMC perspective. So I do think your point there about sort of, you know, what more can the NMC do and how do we actually do that lobbying is a really, really critical one as we move forward. So thank you.
Okay, thank you.
Jenny, did you want to come back in there, or is that a legacy hand?
It's a legacy hand, sorry. I popped something in the chat instead. It's fine.
Brilliant. No worries at all. Mark, let's see if your mic is working.
No, it's not the mic, it's the 67-year-old brain that's the problem, Kath. Thank you, everybody. My name is Mark White, and I have a background in community children's nursing, and I'm going to ask you to live on a small journey with me. Apologies for those of you who've heard this anecdote previously, but back in the summer of 1986, before I suspect some people on the call might have been born even, but it was almost as hot as the spring of 2026 has been in some ways, and I was working as one of the community children's nurses at Central Middlesex Hospital at a time when there were less than 50 community children's nurses in the whole of the UK. And I had the pleasure of welcoming a lady called June Jolly, who was chair of Greenwich Community Health Council at the time, where they didn't have a community children's nursing service. And she'd come to see how we did it in Brent, and what lessons she might learn. Anyway, she came into the office, June, and I explained to June that we got she wanted to come and see some clinical visits with me. And I explained that we were going to see a young lady, a 2-year-old, who'd been referred to the team because she'd sustained a scald, and she'd been to the accident and emergency department the night before. And we were going to see this young lady to review her dressing. Arrived, and Jean said, June said to me, how do all these referrals come to you then, Mark? So I said, well, any child attending A&E comes to us for dressings. They don't get referred on anywhere else other than us if they need dressings. And I said, even the GPs are on board with this locally, and they will refer any children they see who need a children's nurse to us. Anyway, we set off into the depths of Harlesden, arrived at this house, knocked on the front door, and this very distressed lady arrived, crying herself. And I said, I'm the nurse, I've come to see your child. She said, the nurse is already here. So I looked somewhat aghast at this, but she had welcomed me in. And there was a nurse dressed in head to toe in dark green, who was standing in front of a terrified 2-year-old, clutching in her hands 2 pairs of plastic forceps, and the child visibly, clearly very upset by what was going on. And I introduced myself as a children's nurse, and she rapidly threw the forceps on her dressing field and said, and explained that she'd had a referral from the GP to come and visit. And I said, would you like me to take over? Which I did, and she left with her tail between her legs. And I suggested to the mother that we might like to give the child some paracetamol, perhaps a cold drink, something to settle her down. Could we play a game with her, perhaps, while the paracetamol took its effect? And just get to know the child a little before, and for the mother to feel comfortable in our presence, and for the child to feel comforted by the fact that the mum felt comfortable. Anyway, not surprisingly, the child was not completely persuaded by what I considered to be excellent childcare skills, but anyway, got on with the dressing, and felt that we did a very good job. And in fact, in the subsequent days when we did the dressings as a children's nurse, I felt that we did a very good job. I felt that as a children's nurse, I had real skills in getting to work with the mother and the child, and to do the dressing, skills that I do not believe that adult nurse who had attended actually had. And it was about the emotional skills that you bring and the practical care. I never used a pair of plastic forceps with a child in my life. We were one of the first one of the first teams in the hospital to insist that we wore gloves rather than using plastic forceps for all our dressings in the community. Children do not like being greeted with 2 pairs of bright blue plastic forceps being thrust at them. And I think what we do need to demonstrate is that the difference that we make is not just an emotional one, it is the practical ones. We bring a practical skill set to care, as well as the emotional skills that we bring. And we need to demonstrate that we are different in so many ways in what we bring to the table.
Thanks, Mark. And I think you've just demonstrated the power of advocacy through narrative as well. And I think we need to keep on telling those stories, as well as actually building that evidence base about the difference that we can make. So, you know, I think I've heard that narrative on a number of occasions, and it's always incredibly powerful, actually. And sort of, you know, and I'm sure that many colleagues on the call will have very similar narratives as well. I can see that, is it Peter Carroll who's popped in the chat box actually about being the only children's nurse in that particular team. Peter, I don't know as to whether you're able to take yourself off mute and actually tell us a little bit more about that experience, if that's possible.
I'll test first. Can you guys hear me? Am I on?
Perfectly.
Yeah,
brilliant. Yes.
I don't want to get into a circle of speech with myself and beyond those sounds. Yes, so I work for the 0 to 19 service, which covers the age range 0 to 19 community. We're supporting the health visitors for the 0 to 5 side and the school nurses for the 5 to 19 side. It's interesting because quite a few of the school nurses aren't. We're 100% on the whole, like, difference between Gillick and Fraser competence. And the thing is, we do a lot of sexual health advice in our service as well. And that was my only concern coming into the service. So my first goal was to put that right, you know, to explain the difference between Fraser being the sexual health side versus Gillick being general consent to treatment side. And yeah, it was just a bit fascinating because I'm also the only guy who works in our service. I work with all ladies other than myself, and everyone's we've got one midwife, myself, and then everyone else is an adult nurse registrant. And I just thought that was interesting, you know, the service, public health nursing. It seems to attract more from the adult nursing side, which is interesting. I'm not saying that's a problem by any means. Especially health visiting, because obviously with the health visiting side, that is a lot of work with the adult with baby assessment too. But yeah, that's oh yeah, I'm Fergal. I'm very jealous, by the way. I do miss NNU. I did my management placement as a student on NNU, and I do miss it, so I am very jealous.
I'm loving that connectivity. And just before I bring Jean in, Peter, presumably a lot of your role then is about education and supporting colleagues who perhaps have actually got that adult background.
Yeah, definitely. Yeah, I mean, the service itself is prevention. That's like, you know, the goal of the Healthy Child Programme. But yeah, with supporting colleagues, absolutely. Yeah, it's and yeah, just some of my colleagues, especially on the health visiting side, you know, they're not even aware that, you know, sometimes children can consent to their own treatments, and that, you know, a big part of children's nursing is empowerment, is, you know, if that young person can consent to their own treatments, I absolutely prefer for them to be able to provide it, you know, if they're deemed to be, show the good level of understanding of what's happening. Because obviously we refer to other services all the time, from physiotherapy, occupational therapy, mental health services. You know, we do a lot of outward referrals from ourselves too. And I always prefer with the young person, you know, when I'm working with teens, if they can provide their own consent, yeah, that's even better.
Really, really helpful. And I think that just picks up on Veronica's theme, actually, that she was talking about our work to empower young people to actually be active decision makers, and sort of, you know, and to take control of their health and well-being with the support of that trusted adult.
Yeah.
Thanks, Peter. Jean, over to you.
Thank you, and thank you for all those contributions so far. I just wanted to talk about the community children's nursing qualification. We have all been led to understand that field-specific training as an undergraduate prepares you, if you're doing child field nursing, to care for a child in any setting. But there are a number of colleagues on the call who deliver services for children who have additional needs, severe complex health needs, and so on, which does need a particular skill and knowledge that isn't really there in the undergraduate programme. Now, I come from Wales. I'm a lecturer in Wales, and we do not have a programme that specifically provides a children's community nursing qualification. And the point I wanted to raise is that those nurses who want to do that are directed to the public health nursing qualification. And when they start the course, they say it's not really tailored to the type of nursing that I will need to do out in the community. So there is a gap there. I think it would be really interesting to know what else is available around the 4 countries. But if people don't feel adequately prepared for what they're being asked to do, then they may shy away from joining children's community nursing teams. And as we know, with the way health services are going, care closer to home, NHS 10-year plan, more expert people will be needed in teams that are delivering care local to where children live. So I just wanted to raise that point. Thank you.
Thanks, Jean. And I can see that Jenny actually popped her hand up immediately. So I don't know, Jenny, if you've got some Scottish experiences to share on that.
Yeah, we've got a group in Scotland called SPENS, which Jean will know about, and I'm still part of this, Jean, but now I'm a representative from my own university. And actually a course was approved last year through Robert Gordon University for children's nursing, but unfortunately it couldn't go ahead because there wasn't enough uptake of people to be able to run the course. So there is the flavour to have these courses out there, and they obviously got the approval for like the whole of Scotland. And I have links with NHS Education for Scotland who I could take that forward for if you want me to, because they're also trying to push community children's nurses from like that sort of like avenue as well. So, you know, if you need a hand, then let me know, because I do have contacts from it all still, and I've still got fluid contacts now because I'm still actively part of SPENS still.
Thank you very much.
Really, really helpful. And I think sort of, you know, these are some of our challenges in terms of the breadth of environments that we're actually covering as children's nurses, and actually supporting colleagues, whether that's in primary care. And I think we've got very few children's nurses in primary care. Is that an opportunity for ongoing influence? That education and training with regard to children's community nursing. We've got a few more than 50 now, haven't we, Mark? Which is always helpful. It has grown, which is great. But then that school nursing and health visiting component, I think sort of, you know, Peter's talked about sort of, you know, the education and training and support, even though they've done the specialist public health programme, as well as sort of, you know, all of that acute element as well. We've got so many areas to cover. Anybody got any experience of working in primary care that they wanted to share or pick up on? I'm just very aware of, you know, Jean's already mentioned the 10-year plan. We've got the neighbourhood sort of developments, integrated care being really progressed, actually, certainly in my part of the world in London. Any reflections and input that people have been having there? Jenny, did you want to come back in?
No, I didn't. I have had roles that have covered like all sort of like fields of nursing though. In Scotland, there's a role called a practice education facilitator that was implemented in 2004, and that was to support students in practice. I had that role. I set it up at the Sick Children's in Edinburgh when it first began. That covered all the primary care, community nursing, school nursing, health visiting, and all acute areas. And I did all of that for Lothian when I did it. So from a perspective of an educator, you can actually see that this is really integral to every element of child health, because actually in order to be able to support families who are health visiting, you need to have had the skills to be able to have that knowledge in primary care. You then need to have it to then pass it on to the school nurses, who then pass it through the education system. And then everyone else who's working around them needs to have that sort of input. So although I haven't got any immediate experience working in primary care, I would say that unless as a field we have that general knowledge, it will just be so dissolved across everything that we won't be able to actually advocate for our children and young people, because they won't have the knowledge and skills. And you'd have seen that I put in the chat that there's a big bit of research being done based on the NMC standards for pre-reg nursing that was done that was introduced in 2020. There's a massive piece of work being done by someone called Mark in Plymouth. I can't remember his surname to the point, but it's huge, and it's looking about whether even that program is fit enough to be able to provide safe and effective paediatric nurses or children and young people's nurses at the point of registration. So, that's everything that covers that. So I think from an education perspective, they're also championing it across the UK too, to make sure that we do that. But from a primary care perspective, definitely, I think if you haven't got that input, how could you actually do your role, if you know what I mean? If you haven't got that cognitive development skills and all of that, then how could you actually be able to quickly assess a child and know exactly whether that was perhaps normal within their parameters, or whether there was something that maybe needed a bit of additional? And you won't have that experience if you're just generic nursing. To give you an oversight of my own training, I'm University of Birmingham, and I did a 4 years honours in '95, 2 years general, which included all fields of nursing, and 2 years paediatrics. So it gave me a really big encompass covering of everything, but not everybody gets that opportunity.
Thanks, Jenny. Really, really helpful. Just reinforcing that sort of education role as well. And I know on last week's webinar, where we were discussing delegation, we had Ibby, who is one of our practice development nurses, who's purely based in the community and doing that ongoing education. But again, I don't think that these roles are consistently embedded. There's a real opportunity as we move forward. Any other reflections from people, perhaps on their personal experience, on sort of, perhaps some acute care perspectives around sort of, safer care being delivered by children's nurses? And just while people are thinking, I'm just, Virgil, if I can just sort of, pick your brains, actually. I'm just aware from a neonatal perspective, you have a really diverse workforce in terms of having midwives, perhaps sort of, registered adult nurses working in that environment. What's the role of the children's nurse there in terms of supporting colleagues and doing that constant education, possibly? Any thoughts?
I think that we're very lucky, because there's an expectation that you'll come with a core set of skills, which is about delivering quality care to the families. And I think when the regional work I do in the Health Innovation Network is all about perinatal services. And so we're trying to shift away from maternity, obstetric, neonatal to a perinatal focus. And so we have those conversations. And actually, I find that when I have ongoing dialogue with my midwifery colleagues, it is very much about that woman and birthing person's labour and birth experience and the whole family. So we'll do lots of stuff where we are about the family. And so there's a really, everyone's tuned into avoiding a traumatic experience for that family around that birth, labour and birth, keeping everyone together. That it feels like very much we spend more time trying to understand the woman's perspective, because up until a certain point it was very much the baby, and it took me quite a while to realize that my kind of patter that I would share with the birthing partner on the way to the neonatal unit was not necessarily the right thing. I realized I needed to tune into more to what the questions they had. It's been, the last couple of years have been phenomenal in terms of the feedback we get around investigations and these reviews, the learning we've taken from that, and the impact that we as children nurses can work in parallel with our maternity colleagues to provide a really robust perinatal experience for our families. It's fantastic. It's really good.
And really, really helpful. I mean, one of the sort of, scribbles that I actually had was that children's nurses are connectors across the system, actually. We build those bridges, we build those partnerships and those relationships as well. And I think you've described that really, really eloquently, and how we're all lifelong learners, actually, throughout all of our work. Any other colleagues got any reflections? Have I missed anything in the chat box? Bernie, you're always good in the chat box. What am I missing? What themes are we seeing?
I think there's something about our own diversity. There's we've got, if what we're going to do is advocate for children, we need to actually have kind of like a workforce that is recognisable to them. And we are a very female workforce, and having men as part of our workforce is a real strength. It's really important. And I also think having people with perhaps more diverse backgrounds and more diverse life experiences coming into nursing and children's nursing is really important. But there was a lovely tradition of, we were all kind of nicely chosen young ladies who came into nursing, and really and truly that is lovely in some ways, but seriously, you want people with different backgrounds, with experience of, I don't know, working in youth work, working, I don't know, on a farm with young people, all sorts of different things. Because I know when we did the ABPN oral history project, some of the really extraordinary backgrounds that people have, where there was never a kind of a particular intention of them becoming children's nurses, and some of those people have just had such powerful trajectories and such in different perhaps impacts on the world of children's nursing. So I think sometimes we need to shake ourselves up a little bit, or at least open the doors and make it clear that people that are perhaps not overtly obviously like us are really important within the profession. And I was doing some external review in Dublin last week. Yesterday, I think. Yeah, it was yesterday. But one of the things that really impressed me there was that the assessments, they had a term called universal design. So that all of the assessments were interesting and challenging, but also creative, and creating opportunities for each person on the course to actually shine in the best way that they could. So I think if what we're going to do is encourage people to come into children's nursing, we have to encourage them to come into children's nursing education, and we have to make education both fit for creating people that are fit for purpose and fit for practice and all those sorts of things, but also creating curricula that are interesting and stimulating and accessible and all sorts of other words that I can't think of. But it just blew my mind, some of the things that they were doing and why they were doing that. So that was great.
Really fabulous. And I'm loving that challenge, actually, about how do we keep growing the diversity of our workforce. I had a student nurse working with me just last week, actually, who came from a care background. We've got 22,000 care experienced young people across the capital in London, and we've been specifically working with those young people to support them with access to funded prescriptions, dental care, and opticians as well. And I think the best Christmas present ever for me on the 18th of December was the government announcing that cohort of young people would actually have access to all of those elements just baked in until they were 25, which is really, really fabulous. But the insights that that particular student nurse actually brought from her life experience were just phenomenal. And the fact that she was being supported really actively through her university to actually move towards qualification was just brilliant. So I think there's something about sort of, the range of different backgrounds from a whole variety of different angles that we need to continue to grow. Fiona, over to you.
Going to ask the men on the call whether they'd be willing to be contacted to do a little podcast or something that we can promote male nurses as children's nurses and about your roles. That's the first thing. Second thing is to say that I am aware NHS England has increased the number of apprenticeships across England for nursing, and we have been endeavouring members to ensure that they acquire some of those posts for children's nurses, education and training. And Mark, you won't be surprised by this, but at one point when I was in conversation with the Royal College of Paediatrics and Child Health, paediatricians round the council table were stunned that school nurses were not children's nurses and therefore couldn't deal with certain things. Their response was, but they only deal with children.
Thanks, Fiona. I'm just looking at all of the chaps on the call, actually. Are you all up for being contacted to actually? I think that podcast would be fascinating, actually.
Yeah, sounds like a good idea. Yeah.
Definitely.
There we go. Mark?
Always, Kath, always.
There we go. And I'm looking at Neil. There we go. We've got thumbs up from Neil as well, which is fabulous. And if I've missed any other chaps on the call, then we can absolutely include you too. Jean?
Yes, Michael Tatterton's on the call. So,
oh, Michael,
yeah,
of course.
Please shout out people on the call. We're really grateful to hear from you.
There we go. Fabulous. You're all signed up for a bit more work from Fiona. Brilliant stuff.
Kath, I'll use the more familiar way of gaining people's attention. I do go back to the question I posed in the chat early on. I still do not understand, and I don't think we do as children's nurses fully understand the motivation behind those who would wish to disestablish children's nursing as a separate field or branch. I just don't understand what drives them to it, because they've if you look at what motivates people to become nurses, and I've done lots of interviews, as many people on the call will have done, of people who want to become children's nurses, they will often say they experience some aspect of healthcare as a child, going into hospital, or a brother or sister being in hospital, or one of their parents being in hospital, and they will often use that when explaining why they've wanted to become a children's nurse. And similarly, I think adult nurses, when they're interviewed, they will talk about their experience as a child of either themselves or another member of the family experiencing ill health and requiring nursing care. So I just, given that we all come from that sort of perspective, and a very high proportion of nurses, I think, are motivated at least in part by those experiences, I just do wonder why there are, for want of a better, and I apologise for using this as a catch-all, why there are adult nurses out there who don't want there to be a branch of children's nursing, because I just don't understand it.
And I wonder, and I know that both Fiona and Fergal have just popped their hands up, as to whether they actually understand the complexity that has actually been articulated so eloquently on the call this afternoon. So, we've heard about, the rising complexity of children's health needs and all of that work that Veronica has been doing. We've heard about the increased mental health presentations that we're actually seeing. We've also heard safeguarding actually being referred to. We've heard the challenges, perhaps not quite so loudly, but actually last week we did, with regard to learning disabilities and neurodiversity as well. The health inequalities we've actually had really articulated. Peter's actually picked up on some of that as well. But we've also heard consistently about the system and family complexity as well, and the children's nursing contribution within all of that. And I wonder as to whether there's something about us articulating constantly and really clearly the contribution of children's nursing actually within that. Fiona.
I think fundamentally, having been in rooms with many chief executives over the years, and also chief nurses, it comes down to the pound, shillings and pence. The economics, they think they can move the workforce around. What there is a failure to recognise is the risk by having nurses without the right knowledge, skills and competence in the right place to meet the needs of babies, children and young people. It's only when there's an adverse incident that people take note. And we have lost organisational memory. So speaking to people over the last couple of years, there's a lot of people that don't even remember the BRI inquiry and other things like Clothier. And we need to bring that back to the fore because that's when it hits home. There'll be yet another inquiry. Think about Climbier, Peter, Baby P, etc. And we just go round in circles. So I think we do need to do more about that. The other thing, if one looks at retention, I have spoken to some of our new members that were student nurses, and they didn't find that their education programme was fit for purpose in the first year. They didn't find that there was anything linked to children and young people as such. And some of them were thinking of leaving and going in to be a teacher in a school rather than continue down a nursing career. And off late, I've had to avail myself of the health service. And interestingly, I had x-rays and what have you, and there was a student radiographer there. And the radiographer said to me, it's actually the same for their profession. So there's some generic focus within universities across the board. And it's only when they hit year 2 that they might get anything to do with radiography. I don't know if the educationalists on the line have got anything to contribute in that way.
Thanks, Fiona, and really, really helpful organisational memory, sort of, just really baking that into our ongoing work. I am very aware that we've only got 3 minutes left, so I'm going to whip round sort of, our final few hands. Fergal.
Right, a man from Dublin can speak really quickly. So what I'll say is for decades we've been saying children are not small adults, and then in times of crisis like COVID, children are fine. You can be an adult nurse, we can teach you core skills. So there is a mixed message over time. And my question to think about is, are there modern health systems that exist? Are there countries in this world who don't have specialist children registration? Do they come out as an RGN, a registered general nurse, and then do some specialist one afterwards? And do they have adverse outcomes as a result of that? Because I think if you've got big health systems that do work that way and don't see a negative effect, then there's proof of concept that model might work. Thank you.
Thanks, Fergal. Really, really helpful in terms of comparisons moving forward. And Zoe.
I just wanted to say really that I've been a children's nurse for over 30 years, and I've picked up on a number of occasions, actually, adult nurses have said to me that you don't really need children's nurses because they're a parent and they know when their child is sick. And I think there's a number of parents in the UK whose children very sadly died who would argue that that is not the case, that being a parent doesn't mean that you know everything there is to know about children. But I think that might be one of the reasons why people think, well, you don't need a children's nurse, because actually an adult nurse, if they've got additional skills, they will do. Also, I am still seeing people put RGN after their as a nominal, even though they have qualified very much under Project 2000 or degree qualified. We haven't had RGN training in the UK for over 30 years, but people still consider adult nursing to be a generic training. So therefore, they are capable of doing any of the 4 fields if they choose to. We also have this nursing associate programme, which is generic. And as an admissions tutor in a university, I've had applicants and people who've put on their application form, I've worked in mental health for 20 years. I've done the student nursing associate programme, and now I want to be a children's nurse. I would always query, why are you making that swap when that's not your area of background? So I think there's lots and lots of things really that may contribute to this.
Lots of rich insights there, Zoe. Thank you for your contribution. Very aware that we're at 5 o'clock. Jean, as chair, any final reflections and thoughts from you?
Thank you. Yes, it's been a very rich conversation, as you've said. Just going back to Fiona's observation of people not getting their cohort field specific in the first year, the programs now are interprofessional education for year 1, part 1, and then more sort of joint education, and then some cohort specific, field specific in year 2, part 2, and certainly in part 3. So it is the education validated NMC programs that we're delivering. And the selling point of the interprofessional education, IPE, is that you will understand the teams that you're working with, you'll understand their codes of professional conduct, we will see things through each other's eyes. It's supposed to be a very positive, collaborative way of working. The experience isn't always that way, and people are dissatisfied because the people who are the specialists in where they want to go in the future are not so visible in those first year modules that they're doing within the university. So that's just a little bit about that. I don't know if you want to come back, Kath, with a thought on that.
Yeah, no, thanks, Jean. And I think sort of, you know, it's an ongoing challenge that I think we're going to need to actually pick up as we move forward. What we've heard this afternoon, I think, are some really, really clear themes about that organisational memory and being able to actually articulate that really clearly. We've actually heard about the importance of specialist expertise really mattering in terms of that advocacy, but also amplifying and enabling the voice of the child to actually be heard. The critical importance of sort of, you know, our family-centred approaches alongside that developmental knowledge and insight. That generic systems still need support from children's nurses and access to that specialist knowledge as well. That we're navigators, that we are system advocates as well, and that critically we've got to keep evolving, picking up on this educational component, but also making sure that we are influencing the NMC as we move forward to ensure that we have a workforce that importantly meets the needs of our babies, children and young people and their families as we move forward. As always, Jean has pressed the record button and we will capture this. We'll also bring it together into a summary and we will use it in terms of ongoing work, particularly for our Children's Nursing Celebration Day on the 30th of June. So if you haven't got anything planned, please do have a conversation with your local team, plan something, share it on social media. We've got a whole variety of platforms, Facebook, we've got LinkedIn, we've also got Instagram as well. So we'd love to know what people are locally doing. And if you're not a member of ABPN, then please do join and get involved. There are lots of other webinars actually happening, and as Bernie rightly popped in the chat box, these discussions are so important for the community of children's nursing to come together and to keep advocating, because I think sort of, you know, we get support and power from each other to go back and have these local conversations as well as these national conversations as well. So many thanks to everybody for your contributions this afternoon. Jean, can I bring things to a close?
Yes, of course. Thank you very much. We'll stop recording now. Thank you so much. What an interesting conversation. Thank you. Bye-bye,
Have
everyone.
a nice afternoon. Bye.
Bye.
Thank you. Bye.